tonight. So in spite of all the optimistic talk from the governor and legislative leaders about an on-time or perhaps an even early budget, there are still a few hurdles remaining before all of these sides can declare victory. And one of those is medical malpractice reform, specifically whether payouts to victims should be capped to help doctors and hospitals rein in their rapidly escalating insurance costs. Now, last night we heard from a supporter of the MedMal cap, and tonight we're going to bring you some voices from the other side of this argument. Michael Burgess is the executive director of the New York Statewide Senior Action Council, and then across the table from him is Karen Scharf. She is the executive director of Citizen Action of New York. Welcome to both of you. Thanks for being here. I'm going to start with you, if you don't mind, Michael. Sure. If you would explain why, now senior citizens, this is actually not immediately evident why, or obvious to people why, because heretofore we've focused mostly on people who talk about babies. Right. Right. So if you would explain.
Well, older people, are considered not to have any much economic value because they're not going to, if there's a medical problem and they can't work, they're not working to begin with. So I mean, it's not loss of income, so that's part of it. And then there's also the issues about how many years they're going to live. So that's what makes this a little different, and we want to make sure that patient safety is an issue that our organization is involved in, and we feel that the way to deal with that is to focus on medical errors, And I had a little study here that the Inspector General of HHS showed that 15,000 seniors die every month from medical errors of one kind or another.
Okay, let's unpack this a little bit. HHS, Health and Human Services. That's just in case anybody doesn't know. But when you say economic value, I mean, we are not saying that there is not economic value to the life of grandma and grandpa. That's not what we mean.
In determining their loss, a medical loss or an economic loss, with a younger person who's working, if I were to have a problem medically, then they'd look at, well, how much was my earning power for my family and so forth and so on. And that is not the case with older people, plus they have a shorter period of time to remain living. So, this is an issue for us, as I said, more of the patient's safety, and getting justice, you might say. If somebody is in a nursing home, like has happened before, an Alzheimer's patient drowning in a bathtub, many times the families will sue because they want justice,
And it's not necessarily about money. I mean, I think part of the problem with this whole argument is that it becomes very fraught with an emotional quotient. But the problem is when you talk about insurance, there are dried-eyed factuaries who make decisions based on math and numbers. Not only how many years you would have lived, but what kind of life you would have had and what kind of care you are going to need. So when it's a baby who is harmed in some way, that's an entire lifetime that a person needs care, and it's much more expensive, is what you're saying, than it would be for an older person. But for Karen, for Citizen Action, this is more about advocacy for patients.
That's right. I mean, we have been organizing healthcare consumers and patients for the past 25 years around a variety of different healthcare issues, whether it's federal healthcare reform, state healthcare coverage, Child Health Plus, Family Health Plus. And this has always been an ongoing issue for us because if someone is a victim of medical malpractice and they're going to have the rest of their life affected by that, they need to be able to get the kind of compensation that allows them to continue to live, to get rehabilitation, and to really pay for the pain and suffering and other damages, both economic and non-economic, that they're going to suffer. And what this proposal does is it puts a cap on how much somebody can win in a lawsuit. And the problem with a cap is that it's arbitrary. They made up a number, and they're putting that cap, and no matter what might have happened to you, this is how much you can get, no matter what a jury decides you actually need in order to make up for the malpractice. Okay. And we really think instead of thinking about caps, we should be thinking about how do we prevent malpractice. Okay. Patient safety is really the core of this. Let's prevent the malpractice from occurring in the first place. That's what would not only be better for patients, but would save the hospital's money as well.
Of course, and I think most people would agree with that. That sounds very logical. I think the problem, though, on the other side, as we've heard from the other side, not just last night, but also from the hospitals, in particular Greater New York, and we'll get into that in a second, to how we got to this point, they would say, well, it's just as arbitrary for a jury to hear a terribly heart-wrenching story and give it some astronomical number like 25 million, 27 million that could bankrupt, you would argue, or they would argue, a hospital system. Of course, they are covered by insurance, but it drives up their premiums such that they can no longer afford to provide high-risk services like delivering babies, for example. So what's the response to that?
The response is, I mean, first of all, those kind of jury awards are very rare. Most jury awards are $1 million or less.
Sure.
And secondly, most juries, like you said, it's a matter of fact. They look at the facts of the case, they study it carefully, and they look at what kind of compensation would be reasonable based on what happened. And that's why we have the jury system. It's a very fair system. What really needs to be done, if the hospitals want to save money on malpractice, is to stop committing preventable medical errors.
There's errors. I mean, there's human error. We are only human.
Right, but most of the errors are preventable, and there's been a lot of studies. In fact, most recently, just in February, in the Obstetrics Journal, there was a study by New York Presbyterian Hospital where they actually did a careful process of examining their obstetrics unit, what would prevent malpractice, what would increase patient safety. They implemented those changes, and over the course of 4 years, they went down to virtually no medical errors. I mean, yes, mistakes are going to happen, but they can be vastly reduced. And that's what would reduce the hospital's costs, is if we reduce mistakes. And then when a mistake is made, because mistakes are going to happen, people deserve to be compensated. Yeah. That's why we had over 25 groups today come out against this proposal.
Right. I mean, and it's a very long list. And there's also a long list on the other side as well. I mean, it should be said.
But we weren't at the table.
No. Well, let's get to that then. You were not at the table. And again, I mean, to play devil's advocate, it would have had to be not just a table, but like a football stadium to get everybody in that wanted to be in.
But I think if we really want to reform Albany, I think the days when we just put people who have a provider's stake in health care on the table have got to end. I think the time has come when, AARP, a larger group than ours, they were not at the table. I think that is not proper. I think that there needs to be representatives of consumer groups like them at the table, or us, because these are life and death issues, and we are very concerned about, we think we can actually work with hospitals, and I did it as director of the State Office for the Aging. We started a patient navigator program where we had volunteers working to prevent hospital readmissions by having them follow the discharge plan, a volunteer to go in with them. And this is in the Affordable Health Care Act that the President and Congress wanted to reduce hospital readmissions. It's a big cost. That's aside from what we're talking here. But there are ways that have been proven to reduce medical errors, to reduce costs in health care.
Well, and infection rates, too. I mean, and there's also, I remember talking to Betsy McCoy, and she's been on this program, former lieutenant governor. Her big thing is just wash your hands. Right. And and that we're not talking about something so simple, but that is a crusade that a number of people are on. The thing about the table and being at the table, though, is, again, to be dry-eyed about it, there's a political factor here. And the political factor is that Citizens Action, though, has some clout, and certainly seniors vote, and that's very important, obviously. But you don't have the kind of money that Greater New York had, or that 1199 has, and they have a history of banging the daylights out of different governors during a budget battle, and they needed to be on board, and they won't be on board if you take out the med-mal piece of this deal. And then if the whole deal falls apart, where's the savings from Medicaid?
Well, go ahead.
I was just going to say, I think the idea that the med-mal cap or the fund as part of this is actually real savings in Medicaid is pretty speculative. I mean, you go through a lot of steps of assumptions here. You have to first assume that if awards are limited, that medical malpractice rates are going to go down. Then you have to assume that once they go down, the providers will pass on those savings to the state as the payer and to other payers. And then you have to assume that as that gets passed on, it has a significant impact on medical costs, which are pretty speculative.
You could argue that there will be, in terms of direct correlation to the cost of Medicaid going down, that med-mal has zero to do with that. But in order for the hospitals to sign on to agreeing to limit their own costs, which is what they did. They said, okay, we'll agree to a 4% cap annually, and that if we can't meet that, then the state health commissioner can come in and cut us arbitrarily, but we'll also agree to medical malpractice reform so we can take down our costs or insurance, and in the end of the day, it's a wash. And if they back out, then the whole Medicaid MRT proposal falls apart.
Well, I mean, here's ultimately the governor and the legislature make the decision. Nobody actually has a vote in this final budget except for legislators and the governor. It's good to have agreement. It's good to build consensus, but ultimately, ultimately the legislature votes and the governor can sign or veto, and they should make decisions based on the facts and not based on the various machinations they've gone through. And the facts here are that this cap is unfair to patients, not good for patients, not good for patient safety, and isn't going to save the state money in the long run.
Last word to you, Michael, if you'd like.
Well, I just think we could have had more time on this. If they really want to focus on this and do it right, they should spend more time talking about it and bring in all the affected parties, and we could come up with something probably. But this will have to be between, the trial lawyers aren't going to sign on to it either, and they have a lot of clout, so we'll have to see where that goes.
They have no vote. Neither does Greater New York, neither does 1199, and neither do I. Okay, so there you have it. I want to thank you very much, Michael Burgess. Thank you, and Karen Scharf. Thank you so much for coming in.